years, ATLG has become the frontline drug as an induction agent. And me too, we are using a lot of ATLG in the last 2 years. And I'm eager to listen to Dr. Abraham, sir. So Abraham is the head of the renal division in Lakeshore Hospital, Kerala. He's a high volume renal center, transplant center. Over to you, sir.
At the outset, let me thank the scientific committee and the organizing team for the opportunity and the organizing team for the wonderfully organized meeting. The question that is often debated or asked in renal transplantation is induction immunosuppression really required? Particularly if the match is better than haplo, more so in the era of tacrolimus-based immunosuppression. In today's talk, I would like to answer some of the biological basis of induction and to discuss the recent experience with ATG Fresenius or grafaion, which was launched in our country a couple of years ago. Practically all transplant centers use some form of induction therapy, whether it is bolus steroids or biological agents. It used to be IV cyclosporin once upon a time. What is the biological basis of induction therapy? The number of T cells available to mount a direct immune response to an alloantigen is much higher than the number of T cells available to respond in a physiological manner, for example, to a viral antigen. This is called the precursor frequency, and it constitutes about 10% of the individual's T cell repertoire. So the number of antigen T cells are much higher that's available to respond to an alloantigen. More so, T cells have a pivotal role as drivers and effectors of allograft response. CD4 cells promote differentiation of CD8 cells to that eventually mediate allograft rejection, and also are helpful or modulate the transformation of B cells, which eventually produce B antibodies and various cytokines, and which eventually lead to antibody-mediated rejection. So T cell activation actually leads to both cell-mediated rejection as well as antibody-mediated rejection. The second compelling reason to use induction therapy or the need for induction therapy is the tissue injury that occurs along with the transplantation. During transplantation, there is a lot of injurious things happen like endothelial damage, complement activation, ischemia, reperfusion injury, etc. Today's meeting, actually, somebody was discussing about the way the donor kidney is handled. If it is not handled well, if it is not gently handled, that might lead to endothelial activation, and that itself might be a promoter for rejection. And this T cells and high T cell precursor frequency and tissue injury might conspire to produce a situation of enhanced immunity. And also cell trafficking has a role. Reperfusion injury initiates APC, antigen presenting cell mobilization, and the chemokines liberated from damaged endothelium and parenchyma attract a lot of effector cell into the allograft. So all these eventually contribute to the enhanced immune response that happens at the time of renal transplantation. So what are the factors that influence the need for induction therapy, or the factors that actually enhance the biological or immune response during renal transplantation? The higher T cell precursor frequency, which I mentioned some time ago, then HLA mismatch. Higher the HLA mismatch, higher the T cell precursors will be. And the tissue injury, ischemia, reperfusion injury, and endothelial injury that happen during transplantation increase the need for induction therapy, as it is associated with enhanced risk of rejection. So how do we stratify patients based on various risk factors, and what are the various risk factors available for classifying them? The various factors or the criteria that are considered for risk factor stratification renal transplantation are: one is HLA mismatch. The HLA mismatch is high. If it is more than 3 HLA mismatch, risk of rejection is very high. As compared to 0 HLA mismatch, which is associated with a reduced risk of rejection. The second important aspect is the age of the patient and the donor. Younger recipients are associated with an they have an enhanced immune response as compared to older recipients. And similarly, older kidneys are much more likely to reject as compared to kidney from younger donors. So age of the recipient and the donor are very important as far as the risk is concerned. And if you look at the DSA, preformed DSA, presence of preformed DSA is associated with significantly higher risk of transplantation, and no DSA means the risk is significantly reduced. And the vintage, the dialysis before transplantation is also important. Longer the vintage between dialysis initiation and transplantation, higher the risk of rejection, because the probability of receiving multiple blood transfusion, that enhanced state of inflammation that might occur during the stage of dialysis, all contributes to enhanced immunity and enhanced immune response. So these are the various factors which are involved in the risk stratification. So based on this, how do we classify patients to various categories? Low risk and high risk, and in between we have the intermediate risk also. When I say low risk, means there is no HLA mismatch, less than 50% match, meaning like more than a 50%, like, transplantation between siblings where there is a complete HLA match, and kidney from a young donor, and the recipient is more than 60 years, and there is no detectable donor-specific antibody, and the dialysis vintage is less than 1 year. So these are low risk factors for developing acute rejection. And what about the high risk factors? If the HLA mismatch is more than 3, and the donor is young, less than 30 years, children are much more likely to reject because they have very much enhanced immune response. And elderly donors have reduced immune response, and they require much less immunosuppression. And dialysis vintage of more than 3 years, and detectable DSA, like there are preformed donor-specific antibodies at the time of transplantation. These are also associated with very high risk of rejection during renal transplantation. It's very important to balance immunosuppression with the potential risk of infection. Like we all talk about the risk of rejection, at the same time we need to keep in our mind what is the potential risk of rejection, infection also. Like when you use depleting antibodies like thymoglobulin, etc., like you need to really assess whether the patient is at a risk of developing infection. For example, elderly patients who had recent septicemia or infected vascular access, recent pneumonia, recent urinary infection, all these I would say are increased risk factors for developing infection. So these factors should be taken into consideration when you choose your induction agents. What are the KDIGO recommendations for induction immunosuppression? KDIGO strongly recommends a biological agent as initial immunosuppression as part of kidney transplantation. There's very strong evidence for that. It's level 1A for as use of induction immunosuppression at the time of renal transplantation. The evidence is very strong. And the second recommendation by KDIGO is to use interleukin-2 receptor antagonist as the first line of induction therapy. The evidence is not so strong, it's only 1B. And the third recommendation is to use a lymphocyte depleting agent like thymoglobulin or ATLG Fresenius as apart from interleukin-2 receptor antagonist, because these patients are at an increased risk of developing rejection. So what are the available induction agents now? These belong to two categories. One is non-depleting, the other one is depleting. The non-depleting category, at the moment, we have only basiliximab. Daclizumab, which was available with us, it has been withdrawn by Roche maybe about more than 10 years ago. But most of the senior nephrologists will have plenty of experience with using daclizumab. The depleting category, we have two types of ATG. Antithymocyte globulin by Sanofi, and then ATG Fresenius by also called grafaion. And alanthusumab is the other depleting antibody, which is available in the US, but I believe it is no longer used an induction agent even used. Rituximab is another agent. It is used at the time of, in the case of ABO incompatible transplantation or transplantation of highly sensitized patients. But rituximab, strictly speaking, is not an induction agent because it is not given at the time of transplantation. It is given well in advance. And OKT3 was used once upon a time. It's no longer available. And the currently available depleting agents are ATG, rabbit-derived ATG thymoglobulin, which is originally developed by Genzyme. It's available as Sanofi. The recommended dose is 3 to 6 milligram per kg. The other drug is ATG Fresenius, which is also called grafaion. This drug was initially developed by Fresenius in the 80s, and it is available. Now it's with Neovi Biotech, and the recommended dose is 6 to 9 milligram per kg, either as a single dose or multiple doses. Are these both rabbit-derived anti-thymosin globulin the same or they're different? They're slightly different. I'll come to that. So one is called anti-thymosin globulin, that is the ATG or thymoglobulin. The other one is called anti-T lymphocyte globulin or ATLG. And thymoglobulin is produced by immunization of rabbits with the primary lymphocytes from patients, while grafaion is produced by immunization of T lymphoblastoid cells of Jacquard origin. Both is injected to the rabbit, and the antibodies produced are separated. So thymoglobulin is produced by inoculation of the rabbit with thymocytes from the patients, and the grafaion is produced by injecting lymphoblastoid cell line called Jacquard. And both are rabbit-derived antibodies. Rabbit-derived antibodies are far more potent as compared to horse-derived antibodies. And this is thymoglobulin is extracted by absorption technique by erythrocytes, and while placenta and erythrocytes are used for absorbing grafaion. These are the sequence of events involved in the production of both thymoglobulin as well as ATG Fresenius. And thymoglobulin is associated is available as a lyophilized powder, and ATG Fresenius comes as a concentrated solution. Grafaion and thymoglobulin are different in terms of efficacy and potency. Thymoglobulin is much more stronger and displays a broader and stronger antigen binding capacity as compared to grafaion. If you look at the antigen binding capacity of thymoglobulin as compared to grafaion, it's much higher for thymoglobulin as compared to grafaion for the various receptors and for the various cell lines, and including some HLA class 1 and class 2 molecules. So thymoglobulin displays a much broader and stronger antigen binding ability as compared to grafaion. And grafaion is less immune depleting than thymoglobulin at the usual doses, and preserving the immune system. And the concentration of grafaion that is needed to achieve 50% cytotoxicity for normal lymphocytes much higher than the concentration that is required for suppressing the multiplication of activated T lymphocytes. So in a regular situation, thymoglobulin is far more potent as compared to grafaion. And the potency is, if you compare milligram to milligram, each 1 milligram thymoglobulin is approximately 3 times as potent as ATLG. So that's the difference between their potency. So this drug was launched in our country about a couple of years ago, and a multi-center trial was conducted in our country where the drug was used, and 11 transplant centers were involved in this particular study, and our results were published in Advances in Therapeutics, and our center also participated in the study. It is a prospective multicentric observational study involving about 11 transplant centers. This is a prospective multicentric observational study involving 11 transplant centers, all adult patients who underwent ABO compatible transplant, receiving ATLG was included in the study. Patients were followed up for 12 months post-transplant. The primary outcome measures were overall survival and the death-censored graft survival. And the patients were also closely monitored for various rejections and infections complications like urinary tract infection, CMV, infection, pneumonia, etc. The treatment protocol consisted of the use of ATLG either as a single dose or as multiple doses. The recommended doses varied from 6 to 9 milligram, and the decision was left to the transplant physician to decide on the dose. Some centers administer it as a single dose, while other centers give it as multiple doses. When it is given as a single dose, it was given during anesthesia by the anesthetist as an infusion after diluting in 0.9% normal saline. It is infused. And it was given in the usual pre-medication like steroids and antihistamines are also given. And all patients, of course, received standard immunosuppression, which included prednisolone, tacrolimus, and mycophenolate mofetil. And all received semi-prophylaxis at least for 3 months, and cotrimoxazole prophylaxis at least for 6 months. Whenever there was a graft dysfunction, biopsy was done, and rejections were treated with bolus steroids, and steroid-resistant rejections were treated with thymoglobulin. These were the patient characteristics. 359 patients were studied. Majority were male, 75% were male. The mean dose of ATLG was 6.2 with a standard deviation of 2.2, and the cumulative dose was about 400 milligram. The total dose varied from 100 to 900 milligram. Maybe I think some centers started with a low dose, and when they saw some infective or infectious complication, didn't want to give any further doses. And if you look at the various native kidney diseases, CKD of unknown etiology was the commonest, followed by diabetes mellitus, chronic GN, etc. And more than 47% of patients had a HLA mismatch of 3 antigen HLA mismatch. And significant proportion of them had received some blood transfusion. Of course, all were CDC negative, and then there were HBsAg positive, HCV positive patients also in the group. And a small number were receiving preemptive transplant, and then about 3 patients were receiving retransplants. And these were the outcomes. And overall outcome, the patient survival at 12 months was 96%, and death-censored graft survival was 99%. And the mean creatinine was about 1.4 milligram over a period of 12 months. Graft dysfunction occurred in about 48 patients, and biopsy-proven acute rejection in about 24 patients. It's about 6.7%. And cell-mediated rejection 19, and ABMR in 4, and combined rejection 1. And a few others had a CNI toxicity, asymptomatic rise in creatinine, etc. And all the rejection episodes responded to Solimedrol, and none required higher forms of therapy. Infective episodes included urinary tract infection, sepsis, and pneumonia. And urinary tract infections were the commonest. 7%, it constitutes 7% of all the infections. So the highlights were ATLG was associated 1-year graft survival compared with what's available in the literature. The patient survival and the graft survival were 96.5% and 99.4%. And the graft dysfunction was about 13.4%, and biopsy-proven rejection occurred in about 6.7%. And infectious complications were seen, and then the urinary infection was the commonest type of infection that was encountered. And we also looked at did a subgroup analysis of the high-risk population. Of the 359 patients, 171 had a higher degree of HLA mismatch, and then we will have a look at what happened to them. And they had received a slightly higher dose of ATLG, about 6.8 milligram with a standard deviation of 2.2. The cumulative dose was slightly higher, And the incidence of biopsy-proven rejection also is a little higher among them. And infections are also a little higher among them, but not significantly higher among them as compared to the standard group. So the key takeaways are BPU is biopsy-proven acute rejection is still lower, but slightly higher as compared to the low-risk group. And our center also participated in the study. We contributed about 70 patients, and our center actually more than 80% of patients had more than HLA 300 in mismatch, and we encountered a rejection episode of approximately 6%, and all were biopsy-proven rejection, and all responded to Solimetrol and unrequired ATLG, anti-thymocyte globulin. Infection episodes were common, and few other studies actually looked at compared ATAG with ATLG. This is a study from Tamil Nadu, Coimbatore. They compared thymoglobulin 3 milligram with ATLG of 4 milligram, and they found that both drugs were comparable in terms of rejection and graft survival, and encountered slightly increased risk of mortality and sepsis in the ATG group. And this is a study from Calcutta, which they also came to a similar conclusion with a 6 milligram of ATLG was comparable to 3 milligram of thymoglobulin, no significant difference. There's a study from Delhi group, but they found a slight increased risk of biopsy-proven acute rejection in the grafaion group as compared to thymoglobulin, but the patient survival and graft survival comparable in both groups. And what is the rest of the world look at ATLG? And this is a study done in high-risk patient, 35 immunology high-risk patient, DSA positive but cross-match negative. Patients who were randomized to receive grafaion or thymoglobulin. The dose received was much higher actually, a total of 18 milligram per kg, and thymoglobulin received was 6 milligram per kg. And patient survival and graft survival at 1 year and 2 years were comparable. This is a meta-analysis which was published in Frontiers in Immunology, where 27 randomized controlled trials were included. And the gist of the study is that thymo was actually superior in preventing biopsy-proven acute rejection episodes and steroid-resistant rejection episode, but slightly increased risk of patient loss and infection-related graft patient less death in the thymo group. So concluding, with all the evidence and looking at the pharmacodynamics of ATLG, can be safely concluded that ATLG or grafaion at a dose of 6 milligram per kg is generally cost-effective, efficacious in the standard risk transplant recipients. And in the high immunological risk groups, a higher dose may be recommended. But in this group, actually, thymoglobulin may fare better than ATLG because that's just a much stronger molecule. So in comparison to thymoglobulin, at dose equivalency, it tends to offer slightly less immunosuppression and less reduced likelihood of infection and sepsis-related mortality. And overall, ATLG is a useful addition to the induction armamentarium that is available in our country. So where would I place ATLG? I would place ATLG in between thymoglobulin and basiliximab. For the very low risk patients, I would continue to give them interleukin-1 receptor antagonist. And for the very high risk patients, like those who are highly sensitized, preformed DSA, etc., I would prefer thymoglobulin. And this is for the intermediate group, standard risk and width of maybe 3 antigen HLA mismatch, but there is no preformed DSA. Thank you for your patient hearing.
Thank you, sir. I think through your studies and comparative studies, you allayed fears that this agent can be safely used as an induction agent. So I have just only one question, sir. Do you use only ATLG in all your patients? You said last word that some high-risk patients use ATG.
Yeah, I use in all, depending on the risk category.
Yes, sir.
So the low-risk category, I use basiliximab. Very high-risk category, I use thymoglobulin. For the intermediate risk, I use grafaion.
Thank you, sir. Over to the audience, sir.
Sir, it was an excellent talk. I just wanted to know your practice in having given the induction agent with this molecule of grafaion. If you should get a steroid-resistant rejection, would you still use this to treat the rejection or would you switch to ATG?
No, I would, if there is a steroid-resistant rejection, I would use thymoglobulin to treat that because it's a much stronger molecule.
Thank you.
Use of single dose, sir, or divided dose?
No, actually, we use it at multiple doses. Like, I don't have the courage of giving, 400 or 500 milligram grafaion at the beginning. Like, give it cautiously, maybe 300 milligram or 200 milligram beginning. And the patient is okay, not developing any rejection, any infection episode, then I would give the remaining doses also. I wouldn't want to give the entire dose, whether it is grafaion or even thymoglobulin. I wouldn't want to give the complete dose in the beginning. I would split it and give it over a period of time.
You follow third day with the CDC council? And,
Yeah, look at the CDC count also.
Any other questions, sir, from the audience? If there's no more questions, sir, thank you, sir. Your presentation was very clear and it really given some kind of impetus in everybody's mind that this drug can be safely used as an induction aid. Because there is a lot of confusion happens when we interact with our people that sometimes people are preoccupied with the ATG is the only induction, this is a second line drug. I think from your talk it's clear, somebody has taken a message as this can be safely used as a frontline induction agent. Thank you, sir.
Thank you.
Thank you, sirs. May I request Dr. Vel Arvind, the chairperson, to kindly honor the speaker. Dr. Vel Arvind also took an active part in yesterday's pre-conference workshop. We are very happy to honor him, and Dr. Muruganandam will do the honors.